The goals of therapy for myeloma have changed. It used to be sort of a question of control disease. Really now we're moving into a question of ultimately cure disease is our ultimate goal. We recognize there are a subset of patients who are able to do that. That's still a small subset, and unfortunately we're not able to identify who are those patients going to be. But having said that, what we do know is multiple drugs from different classes used in combination early in the course of therapy can lead to deep responses. Now we're seeing MRD negative responses, and ultimately I think that is our goal of treatment, because now we know that MRD negative states correlate with progression-free survival. The other thing that we do know is a backbone therapy regimen that includes a proteasome inhibitor, and you can argue which proteasome inhibitor, and that varies patient to patient, in combination with an IMiD. Generally, lenalidomide is still our frontline IMiD in the United States. In Europe, it tends to be thalidomide. Steroids, unfortunately, patients don't like steroids. We don't really like them, but they still form a backbone of therapy given their synergy with the other drugs. And more the issue of antibody therapy also in the frontline setting is what we use, and to get, again, deep response. We also want to minimize toxicity, so I think getting neuropathies is not acceptable for us any longer in terms of patient quality of life, and we're quick to either adjust therapy or change therapy if we see that as an issue. Fortunately, the other drugs seem to be quite well tolerated. Hematologic toxicity is something we also monitor and adjust as we need to. I still plan for transplant too, so I use that as sort of part of my frontline package for the majority of patients I see. Patients with comorbidities do present a challenge, but they're the reality of myeloma, as the median age of diagnosis of myeloma is 72. So most patients, by the time you reach that age, come along with a burden of other comorbidities. The most common ones tend to be hypertension and diabetes. But having said that, those are the things that some of our treatments also exacerbate. So if you have diabetes, you may have underlying neuropathy, for example. Obviously, the steroids are not helping your diabetes. We need to do a couple things for patients who are older or patients with comorbidities. First of all, we need to assess them better. And there's been a lot of data from ASCO that shows geriatric assessment needs to be more focused and more codified. And so this idea of a frailty index, a comorbidity score, geriatric score, and we've been using that more and more in our clinics. And you're surprised sometimes, just the eyeball test of a patient is not enough. And some of these geriatrics assessments can be really helpful in terms of picking out what is the best treatment for patients, because they also not just encompass the physical characteristics, they also take into account social characteristics, activities of daily living, independent activities of daily living, social support, which when you're talking about some therapies are very important considerations. The other thing I think that's been important to us is being able to use these drugs, but sometimes adjust the dosing. For example, RVD light. So some at a lower dose of lenalidomide, a lower dose of bortezomib, so less neuropathy in a patient. Older patients tend to get more neuropathy. Lower dose of steroids we recognize now in patients over the age of 75. We automatically will start with half the dose of dexamethasone that we do in older patients. MRD has been very exciting to us in myeloma because we can now achieve MRD. Having said that, there are multiple challenges with it. First of all, we still don't have complete agreement on the best method to assess MRD. The second part of that is MRD is a marrow-based test, so that you can sometimes be MRD negative, but still be PET scan positive, for example. So you can't use just one MRD test alone as your true endpoint and stop therapy. So what we can say about MRD is that clearly it's prognostic in terms of progression-free survival, whichever way you measure it, be that by next generation flow or by PCR-based testing. But Are we able to use it to change therapy yet? And I would say the answer is no, but it is the future. And for example, we are going to be opening a huge trial that we're very excited about through SWOG that is going to perform autologous transplant on patients. Patients are going to get maintenance therapy. One arm will be lenalidomide daratumumab. One arm will be lenalidomide. And then at 2 years, patients will have MRD reassessed. And patients who are MRD negative will undergo a second randomization to either stopping therapy or continuing maintenance therapy. So I'm very excited about that trial because it will answer for us in a randomized, prospective fashion, can you use MRD to guide therapy?